let's just kick on.
Okay, so just so that everyone knows that this session is being recorded, and the session will be telecast on the YouTube channel of BIOS, and so that's for people who are not able to join us. So Vipul, are you able to share your screen with us, and then you can start your presentation? Many thanks. I'd ask those who are listening to ask questions on the chat box, and we'll take the questions towards the end of Vipul's presentation. Thank you, Vipul.
Okay, can you see my screen?
Yes, very, very good. And we can hear you loud and clear.
Okay, so this is a real life scenario. This is a patient that I treated, I think back in 2004 or 2005, within the first 5 years of my consultant practice. 56-year-old walked into A&E at a hospital not too far from us. He was rewiring his kitchen, got electrocuted, and had some pain in his shoulder. So he had an X-ray in A&E. That was the X-ray. He was told that everything looks fine. He was given a sling and sent home with reassurance. He then pitches up in our fracture clinic 4 weeks later, where we repeated the X-rays, and this is what we see. And as you can see on the AP X-ray, although it's difficult to tell, the humeral head doesn't appear to be too much out of place, but on the axillary lateral, he clearly has a locked posterior dislocation. And this is not an infrequent scenario. Diagnosis is often missed in A&E, and we'll go through some of the reasons for that. So my name is Vipul Patel. I'm an orthopedic surgeon, work at Epsom St Helier and the South West London Elective Orthopedic Centre. I just want to acknowledge the contribution of my shoulder fellow, Margot, who has helped put this presentation together. The learning objectives today are very simple: how to diagnose and evaluate a posterior shoulder dislocation, and we will talk about some of the management options. A little bit of basic science. What are the stabilizers of the shoulder? Well, we know that the shoulder relies on soft tissue restraints and dynamic muscle forces to maintain stability. There isn't much inherent bony stability. One of the factors which predisposes to posterior dislocation is if there is excessive glenoid retroversion, or certainly in dysplastic glenoid, sometimes that can be an issue. But in terms of the soft tissue restraints, the primary soft tissue restraint is the posterior band of the inferior glenohumeral ligament, shown in the image in yellow. And that is what protects the shoulder against posterior subluxation when the arm is in internal rotation. Now, it is commonly taught that maybe only 1 in 20 or less of all shoulder dislocations are posterior, but there's a big caveat here. If you look at seizure-related dislocations, then anterior and posterior dislocations are equally frequent. So I think that's an important thing to bear in mind. They certainly have a high recurrence rate, and because of the recurrence, they are predisposed to degenerative changes. They are easily missed, and therefore you really need a high index of suspicion to avoid missing the diagnosis. This is a typical scenario. You have a patient presenting to A&E, following a fall, had an X-ray, an axillary lateral wasn't done, missed, then presents in fracture clinic a few weeks later, and they repeat the same mistake. They rely on the original set of X-rays, inadequate X-rays performed, diagnosis missed, and then this goes to litigation. So this is not an uncommon scenario. How does a posterior dislocation occur? Well, the commonest injury mechanism is when you fall onto a flexed and adducted shoulder. So the humeral head is pushed backwards and it comes out. The other more common mechanisms are related to electrocution or with epileptic or other types of seizures. But why do you get this in this scenario? The reason is that the internal rotators of the shoulder, which include the pec major, the lat dorsi, the teres major, and subscapularis, are far more powerful than the external rotators, which are the teres minor and the infraspinatus. So when they go into spasm, the external rotators stand no chance and the shoulder dislocates posteriorly. Clinical evaluation is like any other shoulder injury. You make sure that there aren't any other major systemic injuries. You perform a neurovascular examination. Typically, the patient will be holding their arm in internal rotation and adduction. And when you try and passively externally rotate the arm, this proves difficult or almost impossible. So when they present late, it often resembles a frozen shoulder. And so inability to externally rotate the arm after a seizure or electric shock is a red flag and should really be referred into secondary care as soon as possible. Some of the associated injuries that you have to keep in mind are the soft tissue injuries, which are bound to have occurred if there's a posterior dislocation. More often than not, what we will see is the reverse Hill-Sachs lesion, and there may or may not be an associated fracture of the lesser tuberosity or the proximal humerus. So just have a look at some representative x-rays. These are all patients that have presented in my practice over the past 20 years. These two are slightly more obvious. You can see that the shoulder doesn't quite look right, and there may be a dislocation. The radiographic appearance can be deceptive. On the left is an anterior shoulder dislocation. Even to the inexperienced eye, you can tell that something isn't quite right. On the right is a posterior shoulder dislocation, and to all intents and purposes, it almost looks like a normal X-ray. The Gothic arch is not disrupted. The humeral head seems to be in the correct place. Here's another patient who presented in my practice. He came off his motorbike, was taken to A&E, and they said, yeah, you've got a proximal humerus fracture. We'll put you in a sling and send you to fracture clinic. Pitches up in fracture clinic, and as per our instructions, we don't accept a single X-ray. He was sent for a trauma series of X-rays, and these are his X-rays. As you can see, he was treated just over 10 years ago. And you can see on the scapular lateral that the humeral head is sitting behind the scapula, and on the axillary lateral, it's very clear that the humeral head is out of the joint. Now, if you're incredibly lucky, you might see this. In my experience, this is not common. This is the typical light bulb sign where the humerus is held in complete internal rotation. But in my practice, this is infrequent. You don't see it very often, and certainly not as good as this. The key thing is that you must get X-rays in more than one plane. An axillary lateral view is a must. It's not uncommon for radiographers to say, oh, well, the patient's in pain, they've got an arm in a sling, you can't do an axillary lateral. There are ways of getting an axillary lateral even when the pain prevents abduction of the arm, even if the patient has their arm in a sling. And all radiographers should be aware of this. These days, the availability of CT has certainly transformed practice. It's very often quicker to get a CT scan compared with an axillary lateral. But this helps in not only understanding the degree of damage to the front of the humeral head, but it helps look for associated fractures. The initial treatment in the emergency department, if there aren't any large associated fractures, is to try and attempt a gentle closed reduction. And the object of the exercise is to disengage the reverse Hill-Sachs. So the head, which is engaged on the posterior rim of the glenoid, needs to be disengaged. And the best way of doing that is to gently flex the arm, increase the internal rotation to disengage it, and then gradually externally rotate. This image actually shows what is referred to as the Milch Maneuver, where you place the arm in 140 degrees of elevation and gently externally rotate, and it usually allows the shoulder to be relocated. However, if a single attempt fails, or if there are fractures, or if there's any other concern, then clearly the patient needs to go to theatre. If the closed reduction is successful, then you would reassess the neurovascular status and immobilize for 3 or 4 weeks. This is often the commonest sling available in the A&E departments, and most shoulder injuries get this, but for a posterior shoulder dislocation, it's the wrong type of sling. You need to immobilize the shoulder in external rotation, not in internal rotation. They usually start physio after 4 weeks, and if they haven't had a CT initially, you do a CT to just assess the size of the Hill-Sachs lesion and any associated bone injuries. If the closed reduction was successful and the shoulder was stable beyond 0 degrees of internal rotation, then you can continue with non-operative treatment and nothing further may be required. However, more often than not, you may need to do an open reduction. This is particularly true for acute fracture dislocations or locked dislocations, which present a few weeks down the line. There are a number of options available, and this depends to some extent on the patient's age and associated injuries. Certainly, additional operative treatment is indicated if the shoulder tends to redislocate in internal rotation beyond neutral. And this is the key thing, that if you bring the patient's hand in front of their belly and the shoulder tends to redislocate, there's no point in putting them in a sling and sending them home. You've got to do something about it. More often than not, these will be defect filling procedures, and we'll go through a range of these and see what's suitable. But occasionally in the older patients, you might have to revert to doing a hemiarthroplasty or a hemi-resurfacing. So this one's easy, even in the era of PROFA. If you have a fracture dislocation, that is an absolute indication for operative treatment. This is that 48-year-old who came off a motorbike. Posterior dislocation with a proximal humerus fracture. Clearly needs open reduction, internal fixation, and you can choose your method of fixation. Less frequently, you'll have somebody who has a very large reverse heel sac. So this patient, 35-year-old gas engineer, got electrocuted, had it reduced in A&E, and then 2 days later, he promptly redislocated. He was given a standard polysling, but you can see that he's got a large heel sac lesion, probably about 30% of the arc of the humeral head. So clearly something needs to be done about this. Now, if this was an articular fracture in the knee, such as the tibial plateau or the distal radius, nobody would bat an eyelid about early operative fixation. But for some reason, we tend to sort of shy away from it in the shoulder. When you explore it, this is what you see. It's a depressed fracture. In his case, because he's young and the bone quality and the articular cartilage is good, technically it's not difficult to elevate it, line it up, and fix it. It's called underpinning, and we've published this about 8 or 9 years ago. The technique works. We've used this on a number of patients subsequently, and it's a good technique in young patients with good quality bone. In the older patients, sometimes they'll have an associated lesser tuberosity fracture. This was another 65-year-old who came in just during the early phase of COVID, and he had a lesser tuberosity fracture in association with a posterior dislocation. And so he had it elevated, underpinned, and the lesser tuberosity fixed. And he's done reasonably well out of that. This technique, which has been published by Christian Gerber's group, is more suitable for the locked posterior dislocations in the younger patients, where you have a large reverse heel sacs. And if you can get a size matched humeral head allograft, then you can take a suitable size, an apple slice out of that and plug it into the defect and fix it with screws. And they published a large series with relatively good outcomes, and most patients having a good return to function in the shoulder. We have done this on 1 or 2 occasions, but it's usually for the very late presenters. Something that the textbooks will mention, and you will be required to know in the exam, is the modified Mclaughlin technique. This is again suitable for late presentations where you have a heel sac which does not exceed 40%, and you basically detach the insertion of the subscapularis and plug it into the defect. A more suitable technique is this technique of remplissage, where you don't detach the subscapularis. You simply split it, put 2 anchors at the margin of the defect, and then repair the subscapularis to that defect. I think most people who do shoulder surgery are familiar with remplissage for conventional heel sacs at the back of the shoulder. So this is just the same principle applied to the front of the shoulder. A hemiarthroplasty may be required in older patients or for chronic dislocations, or certainly if the reverse heel sac exceeds more than 40% of the articular surface, so that patient I showed you as my opening slide. This was him. This was his CT scan. And you can see that he's lost at least 40% of the articular arc of the humeral head. When we explored it, it wasn't in one piece. It was crushed, late presentation. So there was really little alternative but to take the humeral head out. As you can see, the lost part of the humeral head is more than 40%, and he ended up having a stemmed hemiarthroplasty. This was more recent. He's another 67-year-old with a seizure, and again, a very large Hill-Sachs lesion. He again had it reduced, closed, and redislocated within the first week. When you explore him, you can see that he's got a very large reverse Hill-Sachs, but the actual cartilage has been crushed inside. So it's not a depressed fracture like we saw earlier. And this, you can't reconstruct the Hill-Sachs. So in this case, we opted to do a resurfacing hemiarthroplasty, and you position it in slight anteversion so that it covers the defect. And he's done reasonably well after this as well. Patients who have small Hill-Sachs lesions, or I should say reverse Hill-Sachs lesions, often don't need early treatment. You can treat them non-operatively, and a small proportion of them may get recurrence 6, 12, 18 months down the line. This was one such patient. He had a very small reverse Hill-Sachs, but as you can see, he had a posterior Bankart lesion, and he was treated with an arthroscopic posterior labral repair. And that's all he needs, so you don't need to necessarily address the small reverse Hill-Sachs lesions. The complications of posterior dislocations are acute redislocation, and this is quite frequent, particularly if you immobilize them in a polysling. So just remember to put them in external rotation. Stiffness is common, so generally you want to get them moving after 4 weeks. Recurrence is not uncommon, and some of them will develop degenerative joint disease later. The take-home messages are that this is a rare injury, but it's disastrous if missed. You must maintain a high index of suspicion, particularly in patients who have suffered electric shocks or epileptic seizures. If you're going to get x-rays, make sure you get them in more than one plane, ideally a trauma series of x-rays. And obviously in these days with availability of CT scans, most of these patients will have a very early CT scan. And we've talked through the range of treatment options available for this challenging group of patients. Thank you. I'm happy to take any questions.
Fantastic. That was absolutely amazing. Thank you, Vipul. There are lots of questions actually, and I'd just like to very quickly, I'm conscious of time, kick off a couple of questions. So close reduction in ED, that was a good technique which you demonstrated. Now, we've had a few medical legal cases wherein they've said that you might potentially make the dislocation worse, or you might not see a spot of fracture in as you said, there could be associated fracture of the proximal humerus, which could be made worse. So what is your advice? We normally at our trust, if there's a posterior dislocation, if you can see the x-ray very clearly, then you'll attempt it. Otherwise, I always tend to tell them that let's do it in theater under controlled environment with x-rays throughout. What's your advice on that, please?
So I think good quality imaging is important. So if you've got good quality x-rays on which you can't see a fracture, then it's very reasonable to have one attempt at close reduction in A&E. I've done it myself on more than one occasion. And as long as you're gentle about it, you flex up the patient's arm, disengage the Hill-Sachs, and then gradually externally rotate.
Yeah.
It's not a forcible reduction. It comes back reasonably easily. But
yeah.
This is what I'm saying. One attempt is reasonable. If you have failed, then I think repeated attempts are not appropriate.
Yeah.
And obviously, like I said, I mean, 15 years ago, you wanted a CT scan out of hours, you had to call the radiologist and get permission. These days, a CT scan is done even before they're referred to the orthopedic team.
No, that's a very good. Yeah, if you get a CT scan, then you're absolutely sure what you're looking at. So yeah. A lot of take-home messages from your talk, including, you must get an axillary lateral, and you can get an axillary lateral without actually abducting the arm. That was a very, very good slide which you showed. There's one thing which there's a question about, do you always have to immobilize them after reduction into external rotation brace? Because a lot of the trusts do not have the external rotation Itoy type braces. They simply have a brace with maybe an abduction pillow. So is that the standard
Yeah.
practice you recommend?
Yeah, so you're absolutely right. The external rotation DonJoys are not universally available. Availability in our trust is also variable, but inevitably we always have a standard DonJoy ultrasling because we use them for cuff repairs, greater tuberosity fractures and whatnot. So if that's all you have, that's perfectly acceptable. But I think placing the arm in internal rotation after reducing a posterior dislocation, I think you're asking for trouble. So it's worth having, at least one standard DonJoy, which most trusts will keep for patients who've had cuff repairs and things like that. So that's what I would suggest.
There's lots of questions. I think what we'll do is, if you don't mind, if you hang on a little bit more, please, Vipul. There's really a lot of questions on your talk, which was absolutely fantastic. I'm conscious of time, and I'll pass the mic over to Abhi, who is going to introduce Adele, and then we will go ahead with Adele's talk. So thank you very much again, Vipul. If you want to stay back and then towards the end of the talk, thank you.
Perfect. Thank you, Mr. Patel. Yes, we'll come to some questions later. Move on to Mr. Tawakkolizadeh. Adele, you're here? Yeah, absolutely. Thank you. So Mr. Tawakkolizadeh is one of the senior upper limb and shoulder surgeons at King's College. He's the go-to guy if any of us have any problems or complex cases. And the trauma experience is amazing. So we're looking forward to this talk about scapular fractures. And thanks, Adele, for joining us. I'll let you take over. Thank you.
Thanks very much, Abhi, and thanks very much, Sunil, for this invitation. It's a big topic, so 10 minutes is not a lot of time. I'll try to cover as many points as possible, but I'm happy to answer questions at the end. So scapular fractures, we know that they are not common, and certainly out of all the fractures that we see, they constitute quite a small number. They're associated with polytrauma patients, and that's where we see them really at King's as part of the major trauma network. And most of these patients often have other associated injuries. And often this is associated with head injuries, chest injuries, commonly obviously with rib fractures. And also we know that there's a high incidence of brachial plexus injuries with these as well. Abdominal injuries come next in that context. So in terms of the issues around scapular fractures, we know that historically they've always been treated conservatively, and we know that a lot of the patients actually did fairly well with that. And a lot of the techniques and the indications for surgery have moved really with advances in surgical techniques. But in reality, there's actually very few high quality studies that really demonstrate the real advantage in fixation. And this is where there's a lot of still disagreement or problem issues around which cases should really be fixed or not. We know that they're uncommon, and the challenges come really because people can't agree on what cases should really be fixed. And we know that it's because of the complex anatomy and the approach involved, not many surgeons like to operate on these cases. And as a result of it, the evidence is also lacking as a consequence. When untreated, we know they can create problems, and we see this occasionally, and certainly they can present with malunions. They can present with scapulothoracic pain and dyskinesis. They can present with shoulder pain. They can get degenerative changes where obviously the glenoid is involved, and they can get associated rotator cuff dysfunction because of the disruption of the anatomy and the origin of the muscles on the scapula itself. A common version that we probably see more in our practice is the floating shoulder, which effectively is a double disruption of the superior suspensory complex. And that's where there's either a clavicle fracture or an ACJ separation in conjunction with an ipsilateral scapular neck fracture. So effectively, it's either the ACJ or the lateral clavicle along with the glenoid neck. There is several classifications. The Euler and Rudy classification defines these as specific process fractures or scapular neck fractures or the articular fractures, and it's quite a useful way of looking at this. And certainly within that, the floating shoulder falls in the category C. Eidberg classification is a widely used one when it comes to the glenoid fractures. And the OTA classification is effectively a hybrid of the two. And again, it's quite a useful classification to look at. As Vipul highlighted in his talk, getting appropriate x-rays is really critical to try to diagnose these patients. And certainly you do the standard views, but in reality, we always have to get CT scans, and 3D reconstructions can often be very useful to try to delineate this complex anatomy of these fractures. And it's an important part of your operative planning. Now, when it comes to type of scapular fractures, we know that the types that are classically fixed are, based on the meta-analysis that are available, are the glenoid fossa fractures. So most of these are intra-articular fractures, and that constitute, based on this big series, around nearly 50% of the cases. The other cases that are fixed are the scapular neck fractures, which are displaced. And the final group that are commonly fixed are the ones which are associated with a clavicle fracture or the floating shoulders. If you look at the treatment by the location of the fracture, and we divide them into body, the glenoid, and the floating shoulder, the body fractures constitute a big proportion of fractures that we see, and actually most of them can be treated non-operatively. There are not intra-articular fractures, and therefore immobilization with sling for the period of pain and early mobilization is tolerated, and a gradual buildup is a good approach. And we know that these patients can continue improving for a substantial period of time after the injuries. When it comes to indications for the glenoid neck fractures, there are three specific areas that we look at. So one is the medialization, and that is effectively highlighted on these pictures. And we are looking for any displacement which is more than 2 centimeters that might create issues with malalignment and malunion. The second angle we look at is the Glenopolar angle, which is the angle between the glenoid articular surface and the lateral border of the scapula. And we are trying to avoid significant inferior angulation. So we're looking at an angle which is more than 20 degrees. The other angle that we're looking at is on the axillary, on the lateral views, is the angle that the body fracture may make, or the glenoid neck may make. And a significant angulation here can create issues with pain in the scapulothoracic region and the irritation that it may cause. And then we have obviously the standard intra-articular fractures, where we are looking specifically for an articular step or a gap that might create or increase the risk of either instability or degenerative changes going forward. When it comes to the fixation, the standard approach that is used in the vast majority is the posterior approach. And really, the position that is used is normally a lateral position. And effectively, you mark out what the incision is going to be based on the configuration of your fracture. And we'll come to that. The arm is normally placed on a gutter frame on the opposite side, so it allows you to move the arm around, but you need to have free movement of the scapula to be able to go on in front or behind the back to get access to the scapular body freely. The standard approach described is the Jude approach, which is an incision across the scapular spine over to the medial border of the scapula. And with this approach, you're peeling off the entirety of the infraspinatus fossa, and you will see obviously the suprascapular nerve and vessels around the notch, and you rotate the muscle around it to get access to the full body of the scapula, which is a very good exposure. And often in the more complex cases, you may need it. But generally, we try to do muscle sparing approaches where possible, and we do the modified Jude approaches where you're doing a muscle splitting approach between the infraspinatus and teres minor, or whichever interval that you may need to get access to the different angles of the scapula to achieve your fixation. The plate positioning is normally where the good bone is, and we can see from this image on the right that the scapula is very thin. So really, you haven't got really a lot of opportunities to put plates anywhere but the edges effectively. And based on the location of your fracture, you decide where this needs to be done. And the standard plating system often people use is the Acumed scapular plates, which have got effectively scapular body plate, the medial border plate, the lateral border plate, and the acromial plate. So this is a case of a fracture that we had at King's. So you have effectively a fracture that is involving the body, the glenoid neck, and the actual articular surface of the glenoid, as you will see on the axillary views. So for this one, the indication is the displacement at the articular surface as well as the glenoid neck. So for this one, and actually one I forgot to mention is this the clavicle fracture. So we try to address this through fixation of all the elements that were involved. This is another fracture that is involving the acromion process, which is displaced, as well as a significant displacement of the glenoid body. And this was actually a patient that, unfortunately, because of the chest injuries, developed empyema. So actually, we ended up having to do this case several weeks down the line, which made life a lot more difficult. But with the principles that we just discussed, we try to address all the displaced fragments, which is acromial fixation and the fixation of the glenoid neck, as demonstrated. Outcomes, we know that actually, when you look at the scapular fractures, that the results can be pretty good post-operatively. And so in this big series of cases, 83% of the patients actually did excellent or good. And to be honest, that I would say is pretty much our finding as well, where the appropriate fixation and anatomical reduction could be achieved, and early rehabilitation is a key part of that. So this is a systematic review of 22 case series, and effectively when they looked at this, interestingly, what they found is actually the non-operative treatment equally did fairly well, and the operative treatment also had good outcome. And this is where the discrepancy between knowing whether always surgery is indicated comes into question. And effectively, in floating shoulder scenario, there's been several papers. I mean, this is just a case, just one example of it, where effectively treating them non-operatively and operatively demonstrated that fixation generally does better in these scenarios because it improves the glenopolar angle and also it gives stability and enables earlier rehabilitation of the patients. Take-home messages. There is a high incidence of associated injuries with the scapular fractures. Generally, all scapular body fractures and the undisplaced fractures, which is the vast majority of patients, can be treated conservatively. In young patients with displaced clavicle fracture, but a reasonable alignment of the scapular fracture and where there is no significant glenoid articular displacement, you can treat the clavicle only. And if there is significant disruption to the glenoid articular surface and the scapular body, you may have to do a more comprehensive fixation of all the elements. It needs to be done by someone who does this type of surgery more regularly, and this is not for surgery for someone who does it on a rare occasion. And it's important you try to restore the angles that we discussed to try to achieve or at least optimize the outcome. And the posterior approach is the standard approach that we use, and we try to do muscle preserving and through muscle splits rather than detachment as much as possible. But the reality is that there is a need for much more higher powered studies across multiple centers to try to really come up with a more definitive answers to the questions. Thank you.
Thank you, Adele. That was an excellent talk. Exactly what the others wanted to hear too. One of these statements that you made about the fixing the clavicle only is very reassuring because that's what we have done a couple of times. So at least we know that what we are doing is evidence and experience based. There are a few questions on the chat. I think before that, I had a question. This is basically a day-to-day scenario that you see. So you see a chap with a glenoid fracture on X-ray and the glenoid looks completely undisplaced. In your experience, do you find that after doing a CT, there is actually significant displacement that requires fixation?
That's a good question, Abi. In short, I would say that this CT scan, as often is the case, shows a more terrible scenario than what you see on the X-ray images. But I do think if you have concerns, you are largely guided by your CT images, obviously, because they are much more detailed. And I think part of it is that in these scenarios, obtaining optimum X-rays can be a bit difficult in the early stages. And that's where the CT is often more useful. I think the timing also is important, bearing in mind you have got a window for these cases to be done. So there's no urgency to be done in the first few days. And based on the fact that they are part of a bigger series of injuries often, you need to take that into consideration as well. But I think final decision-making, I would say, is largely based on the CT images in context of the patient characteristics and the other injuries involved.
Perfect, thank you. I'll read out one more question from the chat and then hopefully we can take some more question at the end. Let's see. So what would be the absolute indication to fix a fracture of the body if the glenoid is not involved?
There is, in my opinion, no absolute indication for such a case.
Yeah, I would agree completely. Perfect. Thanks, Adele. So hopefully we can just get some more questions at the end of the webinar. But if that's okay, I'll move on to Harvinder now to talk about proximal humerus fractures.
Right. Thank you.
Yeah, hang on. Let me say some good things about you. I mean, some people might not know you. So Mr. Singh, Professor Singh, in fact, he was one of the senior trainees when I was starting on my rotation. Everyone looked up to him for his knowledge and skills, and clearly he has carried that on as when he became a consultant. He's now very well known in the region. He's a frequent contributor to BIOS and a reviewer for various journals. So we look forward to hearing this talk from a very senior and experienced surgeon. Thank you, Harvinder.
Thank you, Abhinav. Can you hear me? Proximal humerus fracture. So let's take some examples. This is a 59-year-old gentleman who came off his bike with a displaced proximal humerus fracture with displaced greater tuberosity fracture. How would we want to treat it? Would you treat it non-surgically with surgery or with a replacement? Another example of a 67-year-old patient who had a displaced proximal humerus fracture with a GT fracture with some displacement. Would you want to treat it with a replacement? 69. This is another patient who is slightly on the older side, is 73, again had a markedly painful and displaced proximal humerus fracture with a shaft which is sitting right under the glenoid, extremely painful condition. Would you want to treat it non-surgically? And this is a younger patient, a 49-year-old who again had a markedly displaced fracture, which appears to be 4-part fracture. Would you want to do fixation for this patient? These are the questions which go through the head when the patients are seen with proximal humerus fracture. These are fairly common. They are getting more and more common in elderly and females. It's third most commonest after hip and distal radius fractures, found more in aging population. And most of them, thankfully, are treated non-surgically, but there are certain situations where you do need to choose surgery, and I'd like to discuss those situations. Just briefly to cover the anatomy, there are supraspinatus tendon superiorly, teres minor and infraspinatus at the back and subscapularis at the front. Looking for anatomical neck or the surgical neck fractures, but you need to be aware of these two big muscles which cause problems with these fractures, the pec major and the deltoid, which are notoriously difficult to manage when you're treating these patients surgically. And regarding the blood supply, they come off the axillary artery, the two circumflex vessels, posterior and anterior, and the arcuate branch, which is important for the blood supply of the head. Near came up with the initial classification based on the 4 fragments. But the important thing we forget is the amount of displacement he used to consider more than 5 millimeter or a 45-degree angulation, which was considered in decision-making when considering surgery for these patients. AO kept it simple with extra-articular, intra-articular with unifocal 2-fragment or bifocal with multiple fragments. Hurdle classification is fairly complex, again, considering those 4 pieces in various combinations, but these can be very complex to treat. So in 2015, the PROFA trial was published, and that suggested that surgery and no surgery at 2 years does not make any difference in these proximal humerus fractures. But the important thing we forget is that these patients which were included in the study were in those where the surgeon was uncertain whether he should treat the patient with surgery or without surgery. For the patients or situations where surgeon thought surgery is not required, or they thought that surgery is required, they were not included in this trial. So in the decision-making, these are my thoughts about what are the important situations. So I need to think about whether this patient need an operation. Can they stand an operation? Can this fracture be actually fixed, or do they require a replacement? And the various important factors that I consider. So the important age factor is most important for me. You need to look at the physiology of the patient, their activity level, and to see what is their output looking like. If they are sedentary or very active, that determines how these fractures are to be managed. And then the next important factor is to look at the displacement. Are they minimally displaced, which are more common? They may not need an operation, or they are moderately displaced, where you may need to do something, or they're severely displaced, where certainly they require some treatment. An important factor there is to look at further investigations. You may need to perform scans to see whether the head fragment is actually enjoined or is completely dislocated. And in those situations, the decision is easy whether they need fixing. But beyond 65, I tend to start to consider a reverse shoulder replacement or a hemiarthroplasty, depending on the age and ability of the patient. And that's what PROFA2 has included in patients over 65. The randomization is between no surgery versus hemiarthroplasty or reverse shoulder replacement. The next important factor is the relationship of the shaft to the head. How displaced is that? Is the head fragment gone into varus, where there's less likely damage to the blood supply, or gone into valgus, where there's more likely there's some damage to the blood supply? Or it is completely displaced, where the medial hinge is broken, it's very likely that there's no blood supply reaching the head. In those situations, you may have to replace that fragment. So the predictors for that, when the relationship to the shaft of the head is disrupted, is the length of the metaphyseal extension, if it is less than 8 millimeters, the disruption of the medial hinge, and also the fracture patterns. The moderate predictors are the number of fragments, the angulation, the tuberosity displacement, whether the head is completely dislocated out of joint or the head is split, where there's likely disruption to the vascularity of the head, and there is a high risk of avascular necrosis, which may mean a second operation in an elderly patient. The other important factor is the relationship of the greater tuberosity to the head fragment, and that has a big implication in terms of function and also achieving good mobility and pain relief. That may need to be reduced, especially if it gets pulled away posteriorly or superiorly, then it may require a separate stabilization. And the comminution, which is again very important, especially there is large medial comminution in the example on the left, where I chose to perform a replacement of the head because there was a big fragment and significant displacement, which would have certainly disrupted the blood supply. The example on the right, there is some lateral comminution, but the head and the shaft relationship is still preserved and is less likely to disrupt the blood supply. And in those situations, you can choose to fix them. So the proximal humerus fractures, they are important. You have to choose the appropriate implant based on the personality of the fracture, the patient factor, the age and the outlook, quality of the bone, your expertise and your experience and decision-making with the patient, what they would want to choose. Certainly in certain situations where it is marked displacement, you can choose to treat them non-surgically, and that can give you reasonable function. But when you have chosen to fix it, you will have various choices to make, whether you plate fixation or screw fixation, whether it is shaft fracture where you want to achieve reduction of the translation, nail fixation can be chosen, or a hemiarthroplasty, or increasingly commonly you have to choose a reverse shoulder replacement. So important tips and pearls when you're coming to plating, then you have to be careful of how high your plate is. It can cause impingement. Try not to dissect too much of soft tissues. The medial cortex needs to be reduced anatomically and held there, and avoid lateral displacement of the shaft, which can lead to, again, disruption of blood supply. Try and place an oblique screw on the inferior medial aspect of the head in the calcar screw, as it is called. Patient need to be informed of all the risks of these complications, especially the axillary nerve and artery injury is not uncommon. Infection risk is quite high. Non-union risk, despite displacement, need for a second operation is also significant. Risk of AVN after plate fixation, which can happen due to screw penetration, can lead to an unplanned second operation unless the patient is counseled properly. So going back to the cases that we saw, the first patient, I chose to fix it with plate and screws because the GT was markedly displaced. Reasonable position was achieved. This is a 69-year-old lady, which we treated non-surgically, a gentleman actually, who achieved good function after fixation. And I do tend to use a nail fixation for surgical neck fracture with translation, as nail can achieve reduction and stability of the fracture. This patient, although fairly young, chose to fix with a hemiarthroplasty because I was concerned about the risk of avascular necrosis. And this patient, where there was a head split fracture with marked osteoporosis, I chose to do a reverse shoulder replacement. Thank you very much. If you have any questions, thank you.
Thank you very much, Harvinder. Excellent talk. I'm sure the trainees would be happy to hear that. And hopefully it'll give them enough ammunition to answer questions in the FRCS. There are a few questions in the chat, but I have a couple of questions if that's okay. So there was a recent publication, and I cannot remember where it was, but they said that in about 30% of patients after fixation, they had to go and perform an open release and metalwork removal because the patients did not have enough movement at 1 year. What's your experience and opinion on that?
Thanks, Abhi. My experience has not been very good on that. I will say I have done a few patients who later on needed release and plate removal, but I distinctly remember a lady who I actually, while taking the plate out, broke her humerus and had to put in a bigger plate afterwards. So you have to be careful. Yes, it can achieve a little bit of movement, but I've not had a great experience with improving the range of movement. Vipul and Adele may have a different experience, but my experience has been a bit mixed.
Cool. Okay. Yeah, thank you.
In my experience, I have to say I've done a few of those, and I think it depends on your indications for it. So the cases I have done have been the younger patient groups where they've had a fixation with a phyllos plate. The anatomy of the shoulder on X-ray looks good, but they are just stiff. And in a way, they want to get a bit better range of motion. And I think where the anatomy of the shoulder still is reasonable, and what you consider is causing the stiffness is the soft tissue element. I have to say, I found the arthroscopic capsular release with a manipulation and a subsequent removal of metalwork quite a useful tool, and I think it helps. I think if the anatomy is distorted and that's the cause of your limitation, then obviously the gains are going to be very limited.
Cool. Thank you. Mr. Patel, anything to add on that?
No, I think Adele has summarized it very well. When patients have, shall we say, a less than satisfactory range of movements, the first thing I would say to anybody who's new to this game is don't blame the plate. It can be due to multiple factors. It can be due to articular malalignment, tuberosity malalignment. It can be due to capsular contractures. It can be due to adhesions in the subacromial space. The plate is the least of your problems. If you're going to address all those other things and you decide to take the plate out as part of that, that's fine. But the worst thing you can do is just list the patient for removal of plate, because that's not going to solve your problems.
Yeah, thank you.
Abhi, so from the trainee's perspective, what I was going to say is that a few more questions in the chat which were sent to us directly. So we'll just get the panelist's opinion. So that from the trainee's perspective, there's a few questions about, so starting with Vipul. So there was one question about posterior dislocation management in patients who have hyperlaxity. So in short, would you consider offering them surgical repair? It's a very loaded question. I know you cannot answer that in a minute, but what are your initial thoughts on that?
My initial thoughts are that I asked myself the question that, is the problem something that I can fix with an operation? So if their soft tissues are constitutionally lax, if they've got genetic issues, Ehlers-Danlos, where the soft tissue is primarily a problem, I don't have a surgical solution for that. So I'm not going to offer them an operation. We have had maybe 1 or 2 patients in the past 15, 20 years where we've referred them on to Stanmore to seek their advice and opinion. But I try and avoid operating on those because I don't think I can make them better with an operation.
No, absolutely. I think as Schultz and myself, I'll probably do the same, and I'm sure Adele and Arvinder will do the same. There's another question about, do you get CT scans for all your posterior shoulder dislocation patients in the follow-up? So you've seen the patient, you've done the reduction, and you're happy with the X-ray. But when you see them in the post-op, let's say post-reduction scenario in 6 weeks, 8 weeks, do you perform a CT scan?
So the answer is no. Well, I mean, we don't get a CT scan for every patient. So if we have good, decent quality X-rays, I have a very low threshold for repeating the X-rays when they come back to our clinics, because often the initial X-rays are done with the arm in a sling. They're not in the right position. So we will often repeat the X-rays. And if we've got good quality X-rays where it shows they've only got a very small heel sag, so there isn't any other bony issue, and there's no other clinical indication, then we won't get a CT scan.
Yeah,
but
that's
if
what
the patient has further symptoms, then we'll arrange further imaging.
Thank you. This question was posted by Karan Alva. So I hope, Karan, you've got your answer. I think what people are saying absolutely makes sense, doesn't it? Unless you have an indication, you wouldn't routinely do a CT scan. There was another question about, how do you measure the amount of bone loss or amount of head of the humerus involved in locked posterior dislocations? What is your metric sort of measurement tool on CT scan which makes you say this is 30%, 40% loss of the humeral head, and this is probably suitable for Empressage or for Mclaughlin's or for a Hemi or for whatever?
So the usual scenario is that we will try and assess it on a CT scan by measuring the angle, the arc of the defect, and comparing it with the arc of the articular surface of the humeral head on an axial CT. And so that gives you an idea of whether it's 30%, 40%, whatever it is. And based on that, you make a judgment. But you've got to remember that most of these patients will often either have had a recurrence very early on, in which case you know that you've got to do something, or certainly if they've come in with a lock dislocation, more often than not, you will have to do something.
Yeah, thank you. This something you mentioned in your talk was very interesting about underpinning, and I don't know what Harvinder, Adele, and Abhi have to say about this. I've not done many cases of underpinning like what you gave a brilliant example of, just like you would elevate the tibial plateau, you would elevate. I've probably done a few Mclaughlins, but not. Is that sort of? Do you find yourself doing? Have you done many of these? And is it just one of, as you said, is it just going and finding the fragment, elevating, and then putting a bone graft and fixing it?
So this is not a frequent injury, and it's only perhaps suitable for the younger patients which have good bone quality. So the heel sacs is actually a depressed articular segment. So when we wrote up that paper 10 years ago, we described 2 patients in that, but I think in the past 10 years, I've probably done another 3 or 4. So I think overall, we might have done about maybe 6, I think.
Mm-hmm.
So it's not a huge series, but it works if you've got good quality bone with one large depressed fragment.
Certainly very attractive, because if I'm honest, I haven't heard of this before, but this was an eye opener. That's very good. Something.
Yeah, so I did one after discussion with Mr. Patel, and it's gone really well. The patient's very, very happy. He's got a full range of motion, no instability, normal articular surface. So yeah, I would definitely recommend that.
Fantastic. And then just moving on to Adele's talk, fantastic pearls of wisdom there, Adele, as always. I can see a bit of gray there, Adele, seeing you after a long time.
Joys of working at King's.
It's just the sign of wisdom. That's all it is. And you said that these fractures, some very good pointers. A couple of things from the trainee's perspective in decision making is that you said that these fractures can wait and to be transferred over to level 1 trauma center or to a place where you have a surgeon interested in these fractures. So what would you recommend is your maximum wait for referral, and how proactive you have to be when you find some fractures in your A&E or your fracture clinics?
I mean, the reality is the really bad ones often have come to us anyway because part of the polytrauma, and they've gone straight to a major trauma center. The isolated ones, I mean, ideally you want to get them done within the first 2 weeks, and it's for the basic principle that the fractures start healing by that point, and it's just a bit easier to manage it in that period of time. But one of the cases that I was showing, we ended up doing it at 6 weeks because, as I say, the patient was very sick and they developed an empyema, and we couldn't touch them, and that really made life very, very challenging. There is no question it is easier to deal with and to fix in that first 2-week window.
Thank you so much. Question for Harvinder about pathological humerus fractures, and this is increasingly getting commoner because of the awareness of cancer and metastasis. And recently I was sent a couple of pathological fractures of proximal humerus. And for the shaft humerus, I think it's slightly more straightforward that you end up nailing them for pain relief. And we know that not many of the pathological fractures heal. Also depends on the type of the pathological fracture. So for the pathological fracture of the neck of the humerus, where often you find yourself not having enough bone on the proximal side to fix it. And I know it's a very open-ended question. What's your approach with the pathological fractures of the proximal humerus?
Thanks, Sunil. So it needs a full workup, MDT discussion, needs an MR, and sometimes I get a CT also in addition, just to look out for how big the tuberosities are. I've done reverses which have dislocated. I've done reverses which have been stable still for 2 years, done hemiarthroplasties. But all I would say is you have to think, once you've excised that proximal fragment, you have to stabilize the head somehow. And if you do not have soft tissue there, be prepared for that hemi to dislocate. So you have to tell that patient that it will dislocate. The reverses will function well, but again, the soft tissues around it are very, very critical. If you are not certain about the soft tissues, then a simple operation, just put a hemi and keep it there for whatever the patient's life remains, and pain-free is the most important thing. But I would not shy of doing investigations to find how big the tuberosities are, whether I have soft tissues to repair, and having just a frank conversation with the patient and the family, saying, looking at the longevity. It's very difficult to ask the oncologist. They'll always say 2 years, and then you say, oh God, then you have to think of a definitive procedure, but it's not an easy question. Thanks.
Thank you. So I know we said that we're going to keep this session bite-sized. Last question from my side is what you said, Harvinder, about the PROFA study, amazing work done by Amarangan and his colleagues, is that the fractures where the surgeons had decided to operate or not to operate were not actually included. It was those question where you found yourself at the equipoise. That's when the fractures were considered in that. So I just wanted to ask the panel here, what is your your 1 minute take on proximal humerus fractures which are displaced? If I can start with Vipul, please. Thank you, Vipul.
So I think that with PROFA, we are perhaps more mindful about which ones we operate on. But I think when you've been in the game long enough, you realize that some of the really badly displaced ones are not going to do well with non-operative treatment. So certainly if there is complete displacement of the surgical neck, we will offer them fixation. If there is significant displacement of the greater tuberosity, we will offer them fixation. So it's really the less displaced ones where everything is reasonably in the right position where we will offer them the option of non-surgical treatment. And certainly the older they are, then lower the demands they place on their arms, then more likely we're going to veer towards non-operative treatment.
Thank you. So in essence, your threshold for offering surgery has gone slightly higher up after PROFA. That makes absolute sense. Adele, please.
I have to say, considering PROFA effectively included 20% of the patients that actually were they were appropriate for the trial. They reached the inclusion criteria. 20% were actually recruited for the trial itself, which was the 250. And the cases were largely near 2 and near 3 cases. I think the PROFA does not give you any conclusions when it comes to near 4 fracture dislocations or fractures and the more severe cases. And bearing in mind, at least where we work, a lot of the patients we're dealing with are the younger patients. I wouldn't see the PROFA really guides me personally a lot in that context. But I think for the older population, that represents, I guess, the average sort of residential or district general hospital, I think it enables people to, I guess, justifiably go a little bit conservative if they feel is appropriate. But I do think it does need to be gauged on a case-to-case basis. And as Vipul very correctly said, if they're very badly displaced, they need fixing. And I think it therefore needs to be interpreted with a degree of caution, the trial itself.
Fantastic. Thank you. Thank you very much, all the panelists, for sparing your time on this very sort of, what's that called? Time of the weekend when it's very precious that you have to spend time with your family, yet you have come on this panel, and excellent talks. Harvinder, thank you so much. Thank you, Vipul. Thank you, Adele. And Abhinav, my co-host, thank you so much for organizing this. And thank you, Mr. Anand, who has been the backbone of organizing these educational seminars for the trainees. This recording will be available eternally.
One second, sorry, Sunil, there are a couple of questions in the chat. Let's just go through these. So, question from Amit Goyal. how do we immobilize the shoulder in ED after reduction of a posterior dislocation if there is no provision to immobilize in external rotation? So probably for the panel, if any suggestions, if you don't have a brace available.
I think you have to be proactive about this and make sure that you keep at least one Donji ultra sling. So we have a split arrangement. As you know, our trauma is done on a different side from the elective surgery, but we'd keep at least one or two Donji ultra slings on the trauma side so that they are available. So that's what I would say, is that you may get caught out once, but if you get caught out once, then you've got to take steps to prevent getting caught out twice.
So your advice would be to all the people in this talk is to procure one, at least one, to keep it in your department in case such a scenario arises.
Absolutely.
Perfect. Thank you. Any other suggestions on that from the panel?
See, I have to say, my confession is that I've never used splintage and external rotation. But if you really do get stuck, I have on occasion used a pillow on the side of the patient, and that was stuck with a tape around, and then used the normal sling on the side, which gives it a degree of external rotation.
Yeah. No, I've seen that being used, but yeah, I mean, obviously it's convenient to have the Donjoy brace available.
Absolutely.
There's a question from Aravind Desai. I think Mr. Patel has already answered this. Any role of bone graft substitutes in such cases of depression? I presume this is to do with underpinning technique. Mr. Patel, you answered allograft bone chips. Is that something you would always use?
So we haven't always had to use it. For the younger patients, you elevate it and the fragment is so strong that you don't need to put anything underneath it. For the older patient, it's like dealing with a tibial plateau fracture. I mean, what would you use for a tibial plateau? I mean, we occasionally use allograft bone chips, so and we have them on the shelf. So if they're available and you feel the need, then you can use them. So that's fine.
Perfect. Thank you. I think the last question here was from Sunil. Was it from you, from BIOS? Great approach for missed reduction. If it's a 6-month-old posterior dislocation that has been missed, would you use the posterior?
That must be our boss, the president.
That is me.
Mr. Tola.
Thank you.
Right. Hi.
It's answered by Vipul, I think. Vipul's already done it.
So yeah, as Mr. Patel says, you would always use a deltopectoral approach, because you have to do some sort of anterior repair, either to deal with the hill sacks.
So one of the top tip I would add is that when you're doing a deltopectoral approach, in terms of trying to disengage the locked head from behind the glenoid, one of the most important pearls I can tell people is to make sure you have a laminar spreader available, because that just helps to distract the humeral head from the glenoid, and it allows you to reduce it without causing further damage. But
Thank you.
I've got no experience of going in through the back.
I reviewed a paper recently that Harvinder sent to me, and there was this technique where they were recommending, and they were very nice diagrammatic representation of using the arthroscopic posterior portal. So you insert an instrument from the back, and then lever the humeral head out whilst you're doing your deltopectoral approach from the front. So I thought that was quite a handy way of doing it. I'll try it next time if I get a chance.
Just keep a laminar spreader handy.
Yes, I will. Thank you. I think that's the last question here is Arvind Desai. Any experience on liquid calcium sulfate for proximal humerus fractures? I'm not sure I understand the question fully. Harvinder, do you have?
No, I've never used it. We got DBM putty with chips that I've used for proximal humerus fractures, especially to support it from collapsing in abduction type of injuries. I think it's critical to put bone graft behind the head to stop it coming back into abduction. But I've never used the calcium sulfate, no. Others might have that experience, yeah.
Perfect.
Abhi?
Yeah, sorry, Mr. Patel.
Yeah, so I have used bone graft substitutes, and the one I found which works best is Kronos, which is hard. It comes as a wedge, so in those impacted fractures where you've just got an empty void behind that, you can put it in inside the neck, and it will hold things up whilst you're putting your plate on. So that's quite useful. And we have limited experience with using the cement augmentation, which was available from Synthes, where you had the hollow screws and you could inject cement through them. So in very osteoporotic bone, we've used that on a few occasions. So that helps to just supplement your fixation.
Yeah, certainly those two methods I have tried as well. And I do agree that the Kronos wedge is probably the best one. I think Professor BJ Singh, I don't know whether he's logged in now. He used to have a fibular allograft available for almost every case. And that works really well as well. I think there's a published series about it. But I don't know how easy that is to organize. Cool. Okay, Sunil, sorry, do you want to wrap up? You were talking about the recording.
Yes, so no, the recording will be available for eternity on YouTube BIOS channel. So yes, and so people can really benefit from an absolute, amazing talks this morning. 3 talks with great experts and great pointers, not only for the trainees, I think for the surgeons at every level, whatever level you are practicing orthopedic surgery, including specialist shoulder surgery. So I cannot be so grateful to all of you for this, your precious time. Thank you very much. We bring this to a close now, and thank you all for joining.
Thank you, Mr. Patel, Adel, and Harvinder. Thank you for your talks and your time.
Thanks, Sunil and Abhinav and BIOS for organizing this. Thank you.
Thank you, guys, all of you.
Bye.